1 out of every 9 Americans has chronic kidney disease. As the stage of kidney disease progresses, the mortality rate also increases. The last stage of kidney disease, end-stage renal disease, or ESRD, occurs when the glomerular filtration rate is less than 15 mL per minute. At this point, renal rate is less than 15 mL per minute. At this point, renal replacement therapy, dialysis, or transplantation is required to maintain life. Despite all the technological advances in life-sustaining treatment with dialysis, patients with ESRD have a high mortality rate. As the stage of kidney disease progresses, rates are as high as 19 to 24% for individuals with ESRD on dialysis. More than 26 million American adults have chronic kidney disease, and a million more are at increased risk. Over 500,000 Americans are receiving treatment, either dialysis or transplant, for end-stage renal disease. Individual resulting in a chronic kidney disease being underdiagnosed and untreated. It's been estimated that about 70% of people with chronic kidney disease are unaware they have the disease. Kidney disease improving global outcomes clinical practice guidelines defines chronic kidney disease as either the presence of kidney damage or a decreased glomerular filtration rate less than 60 mL per minute per 1.73 meters squared for longer than 3 months. At this point, again, renal replacement therapy, either by dialysis or transplantation, is going to be required to maintain life. The leading causes are diabetes, about 50%, and hypertension, about 25%. Less common etiologies include glomerular nephritis, cystic diseases, and neurological diseases. Because the kidneys are highly adaptive, kidney disease is often not recognized until there are considerable loss of nephrons in minority populations, especially African Americans and Native Americans. Hypertension and diabetes mellitus are also more common in African Americans and Native Americans. In African Americans, the risk for chronic kidney disease as a complication of hypertension is significantly increased. African Americans have the highest rate of chronic kidney disease, nearly 4 times that of whites. Native Americans have a rate of chronic kidney disease twice that of whites. The rate of chronic kidney disease is 6 times higher among Native Americans with diabetes than among other ethnic groups with diabetes. Hispanics have a high rate of chronic kidney disease, Native Americans with diabetes, than among other ethnic groups with diabetes. Hispanics have a high rate of chronic kidney disease, 1.5 times higher than non-Hispanic whites. Kidney disease is staged based on glomerular filtration rates, with stage 1 beginning at less than 90 mL per minute per 15 mL per minute per 1.73 meters squared. The prognosis and course of chronic kidney disease are highly variable depending on the etiology, patient's condition and age, and adequacy of healthcare follow-up. Some individuals live normal, active lives with kidney disease, whereas others may progress rapidly to end-stage renal disease or stage. The United States has covered the majority of the costs of providing dialysis through Medicare benefits. Under Title 18 of the Social Security Act, ESRD was recognized as a disability. Medicare pays for 80% of the eligible charges, with the remainder being paid by state or private insurance or out of pocket. The clinical manifestations are a result of retaining substances including urea, creatinine, phenols, hormones, electrolytes, and water. Uremia is a syndrome in which the kidney function declines to the point that symptoms may develop in multiple body systems. It often occurs with glomerular filtration rates of 15 mL per minute or less. The manifestations of uremia vary among patients according to the cause of the kidney disease, comorbid conditions, age, and degree of adherence to the prescribed medical regimen. Many patients are tolerant of the changes caused by declining kidney function because they occur gradually. As kidney function deteriorates, what can develop? We will look at some of the systems individually. As the glomerular filtration rate, or GFR, decreases, the BUN and serum creatinine levels increase. As you can see, there are many reasons why the BUN is increased, not only by kidney disease, but also by protein intake, fever, corticosteroids, and catabolism. For this reason, serum creatinine clearance determinations are considered more accurate indicators of kidney function than BUN or creatinine. Significant elevations in BUN contribute to development of nausea, vomiting, lethargy, fatigue, impaired thought processes, and headaches. fatigue, impaired thought processes, and headaches. Patients with diabetes who develop uremia may require less insulin than before the onset of the chronic kidney disease. Insulin, which depends on the kidneys for excretion, remains in the circulation longer. Insulin and glucose metabolism may improve, but not to normal values, after the initiation of dialysis. As a result, individuals who required insulin before starting dialysis may require less insulin therapy when they start dialysis and their kidney disease progresses. Insulin dosing must be individualized and glucose levels monitored carefully. Hyperinsulinemia stimulates hepatic production of triglycerides. Many patients with uremia develop dyslipidemia with increased very low density lipoproteins or VLDLs, increased low density lipoproteins or LDLs, and decreased high density lipoproteins or HDL. The altered lipid metabolism is related to decreased levels of the enzyme lipoprotein lipase, which is important in the breakdown of lipoproteins. Most patients with chronic kidney disease die from cardiovascular disease. In the early stages of chronic kidney disease, patients do not usually report any change in urine output, since diabetes is present, but not necessarily as a consequence of kidney disease. As chronic kidney disease progresses, patients have increased difficulty with fluid retention and require diuretic therapy. After a period on dialysis, patients may develop anuria. So let's talk about electrolytes. Potassium. Fatal dysrhythmias. Potassium. Fatal dysrhythmias can occur when serum potassium levels reach 7 to 8 milliequivalents per liter. Hyperkalemia results from the decreased excretion of potassium by the kidneys, the breakdown of cellular protein, bleeding, and metabolic acidosis. Potassium may also come from food, dietary supplements, drugs, and the next is sodium. Sodium may be elevated, normal, or low in kidney disease. Because of impaired sodium excretion, sodium along with water is retained. If large quantities of water are retained, dilutional hyponatremia occurs. Sodium retention can contribute to edema, hypertension, and heart failure. Sodium restricted to 2 grams per day. We'll talk more about calcium and phosphate in the sections under the musculoskeletal system. So finally, we'll talk about magnesium. Magnesium is primarily excreted by the kidneys. Hypermagnesemia is generally not a problem unless the patient is ingesting magnesium, such as milk. Milk of magnesia, magnesium citrate, and acids containing magnesium. Clinical manifestations of hypermagnesemia can include absence of reflexes, decreased mental status, cardiac dysrhythmias, hypotension, and respiratory failure. Patients with chronic kidney disease can develop metabolic acidosis. The average adult produces 80 to 90 milliequivalents of acid per day. This acid is normally buffered by bicarbonate. In kidney failure, plasma bicarbonate levels to a new steady state at approximately 16 to 20 milliequivalents. The decreased plasma bicarbonate reflects its use in buffering metabolic acidosis. The bicarbonate level generally does not progress below this level because hydrogen ion production is usually balanced by buffering from the demineralization of the bone, which is the phosphatic normochromic anemia is associated with chronic kidney disease. Anemia in chronic kidney disease is due to decreased production of the hormone erythropoietin by the kidneys. Erythropoietin normally stimulates precursor cells in the bone marrow to produce RBCs. Other factors contributing to anemia are nutritional deficits, decreased RBC lifespan, increased hemolysis of RBCs, frequent blood samplings, and bleeding from the GI tract. Sufficient iron stores are needed for erythropoiesis. Many patients with kidney disease are iron deficient and require iron supplements. Folic acid, which is essential because it's water soluble. Therefore, it needs to be supplemented in the diet. Defect in platelet function is caused by impaired platelet aggregation and impaired release of platelet factor 3. In addition, alterations in coagulation systems occur because of increased concentrations of both factor 8 and fibrinogen. The most chronic kidney disease is cardiovascular disease. Leading causes of death are myocardial infarction, ischemic heart disease, peripheral arterial disease, heart failure, cardiomyopathy, and stroke. Cardiovascular disease and chronic kidney disease are so closely linked that if patients develop cardiac events such as a myocardial infarction or heart failure, kidney function is evaluated. Traditional cardiovascular risk factors such as hypertension and elevated lipids are common in chronic kidney disease patients. Cardiovascular disease may also be related to non-traditional cardiovascular risk factors such as vascular calcification and arterial stiffness. The calcium deposits in the vascular medial layer are associated with stiffening of the blood vessels. Mechanisms involved are multifactorial. They include vascular smooth muscle cells changing into chondrocytes or body amount of calcium and phosphate resulting from abnormal bone metabolism, impaired renal excretion, drug therapies to treat bone disease. Chronic kidney disease patients may present with respiratory symptoms. With severe acidosis, the respiratory system may attempt to compensate with Kussmaul breathing, which results in increased carbon dioxide. Pneumonia may occur as a manifestation of fluid overload, pulmonary edema, uremic pleuritis, pleural effusions, and respiratory infections such as pneumonia. In the GI tract, you might see things like stomatitis with exudates and ulcerations, a metallic taste in the mouth, and uremic fetor, which is a urinous odor to the breath. Anorexia and vomiting may develop if chronic kidney disease progresses to end-stage renal disease and is not treated with dialysis. Diabetic gastroparesis, which is delayed gastric emptying, can compound the effects of malnutrition for patients with diabetes. GI bleeding is also a risk because of mucosal irritation and the platelet deficit. Constipation may be due to the ingestion of iron salts and or calcium-containing phosphate binders. Limitations on fluid intake and physical inactivity can increase the risk for constipation. The central nervous system can become depressed, resulting in lethargy, apathy, decreased ability to concentrate, fatigue, and coma may result from a rapidly increasing VUN and hypersensitive encephalopathy. Peripheral neuropathy is initially manifested by slowing of nerve conduction to the extremities. Individuals with advanced stage 5 chronic kidney disease may complain of restless leg syndrome, described as feeling as if bugs are crawling inside the legs. Paresthesias are most often experienced in the legs and feet and may be described by the patient as a burning sensation. Eventually, motor involvement may lead to bilateral foot drop, muscle weakness and atrophy, and a loss of deep tendon reflexes. Muscle twitching, jerking, asterixis, which is a hand flap reflexes. Muscle twitching, jerking, asterixis, which is a hand flapping tremor, and nocturnal leg cramps can occur. In patients with diabetic neuropathy, symptoms can be compounded by uremic neuropathy. Dialysis should improve general central nervous system manifestations and may slow or halt the progression of neuropathies. Motor neuropathy may not be reversible. The treatment of neurological problems is dialysis or transplantation. Altered mental status, a late manifestation of chronic kidney disease stage 5, rarely occurs unless the patient has chosen not to have renal replacement therapy. Activated vitamin D is necessary to optimize kidney function deteriorates. Less vitamin D is converted to its active form, resulting in decreased serum levels. Low levels of active vitamin D result in decreased serum calcium levels. Serum calcium levels are primarily regulated by the parathyroid hormone, PTH. When hypocalcemia occurs, the parathyroid gland secretes PTH, which stimulates bone demineralization, resulting in calcium from the bones. Phosphate is released as well, leading to elevated serum phosphate levels. Hyperphosphatemia also results from decreased phosphate excretion by the kidneys. Hyperphosphatemia decreases serum calcium levels and further reduces the ability of the kidneys to activate vitamin D. Chronic kidney disease can also affect the integumentary system. A small percentage of patients develop a refractory pruritus that can have a devastating impact on their well-being and quality of life. Pruritus has multiple causes, including dry skin and neuropathy. Pruritus is more prevalent in patients receiving dialysis than in the early stages of chronic kidney disease. The itching may also be so intensive that it can lead to bleeding or infection secondary to scratching. Uremic frost is an extremely rare condition in which urea crystallizes on the skin. This is usually seen only when VUN levels are exceeded. There are ways in which the reproductive system responds to chronic kidney disease. Women usually have decreased levels of estrogen, progesterone, and luteinizing hormone, which causes anovulation and menstrual changes such as amenorrhea. Men experience loss of testicular consistency, decreased testosterone levels, and low sperm counts, and menstrual changes such as amenorrhea. Men experience loss of testicular consistency, decreased testosterone levels, and low sperm counts. Sexual dysfunction may also be caused by anemia, which causes fatigue and decreases libido. In addition, peripheral neuropathy can cause impotence in men and anorgasm in women. That may cause changes in sexual function or psychological problems such as anxiety or depression, physical stress, and side effects of medications. Sexual function may improve with maintenance dialysis and may become normal with successful transplantation. Patients who become pregnant while receiving dialysis have been able to carry a fetus to term, but kidney transplant is more common, but there is still considerable risk to both the mother and the infant. Psychologically, the patient may have fatigue and lethargy contributing to the feeling of illness. The changes in body image caused by edema, integumentary disturbances, and access devices such as fistulas and catheters may contribute to the development of anxiety and depression. Decreased ability to concentrate and slowed mental activity can give the appearance of dullness and disinterest in the environment. The patient may also deal with significant changes in lifestyle, occupation, family responsibilities, and financial status. Long-term survival depends on medications, diet. The patient also grieves the loss of kidney function and independence. Because persistent proteinuria is usually the first indication of kidney disease, screening for chronic kidney disease involves a dipstick evaluation of protein in the urine or evaluation of albuminuria, which is not detected on a routine urinalysis. Patients with diabetes need to have an examination for albuminuria if none is detected on a routine urinalysis. A person with persistent proteinuria, 1 plus protein on a standard dipstick test 2 or more times over a 3-month period, should have further assessment of risk factors and a diagnostic workup for blood and urine. A urinalysis can detect red blood cells, white blood cells, protein, Cas, and glucose. An ultrasound of the kidneys is usually done to detect any obstructions or determine the size of the kidneys. Other diagnostic tests help establish the diagnosis and cause of chronic kidney disease. A kidney biopsy may be necessary to provide a definitive diagnosis. Glomerular filtration rate is usually calculated using 2 equations, the Cockcroft-Gault formula or the modification of diet and renal disease study equation. Early recognition, diagnosis, and treatment can prevent the progression of kidney disease. It's important that patients with chronic kidney disease receive appropriate referral to a nephrologist early in the course of the disease. Every effort is made to detect and treat potentially reversible causes of kidney failure, such as heart failure, dehydration, infections, nephrotoxins, urine tract obstruction. Glomerular nephropathy disease have a high incidence of cardiovascular disease. A higher percentage of patients will die from cardiovascular disease than will live to need dialysis. When a patient is diagnosed with having chronic kidney disease, therapy is aimed at treating the cardiovascular disease in addition to slowing the progression of the kidney disease. A focus on stages 1 through 4 before the need for dialysis, controlling hypertension, hyperparathyroid disease, chronic kidney disease, muscle bone deterioration, anemia, and dyslipidemia. The following slides focus primarily on the drug and nutritional aspects of care. Chronic kidney disease always leads to concerns about potassium. When we talk about potassium, we want to consider both hyperkalemia and hypokalemia. Multiple strategies are used to manage hyperkalemia, including restriction of high potassium foods and drugs. Acute hyperkalemia may necessitate treatment with IV glucose and insulin or IV 10% calcium gluconate. And how do these drugs work? Well, insulin shifts potassium into the cells by the insulin. Calcium gluconate raises the threshold of cardiac excitation, and sodium bicarb may also be added to shift potassium into the cells. Sodium polystyrene sulfonate, or KXLate, is a cation exchange resin and is commonly used to lower potassium levels. In stage 4 chronic kidney disease, it can be administered on an outpatient basis. Sodium polystyrene sulfonate has an osmotic laxative action and ensures evacuation of the potassium from the bowel. Tell the patient to expect some diarrhea. Never give sodium polystyrene sulfonate to a patient with a hypoactive bowel, as in a paralytic ileus. Polystyrene sulfonate to a patient with a hypoactive bowel, as in a paralytic ileus, because fluid shifts can lead to bowel necrosis. As sodium polystyrene sulfate exchanges sodium ions for potassium ions, observe the patient for sodium and water retention. If changes appear in the EKG, such as peaked T waves or widened T waves or widened QRS complexes, dialysis may be required to remove excessive potassium. Patiromer is an oral suspension that binds potassium in the GI tract and is used to treat hyperkalemia in individuals with chronic kidney disease. It should not be used in emergency situations to treat hyperkalemia because of its delayed onset of action. Because this drug can also bind to other oral medications, it needs to be given 6 hours before or 6 hours after other oral medications. The choice of prescribed medications is dependent on whether the patient with chronic kidney disease has diabetes or not. The ACE, or the angiotensin converting enzyme inhibitors, and the ARBs, or the angiotensin II receptor blockers, are given to diabetic patients and those with non-diabetic proteinuria because they decrease proteinuria and possibly delay the progression of chronic kidney disease. These medications must be used with caution as they further decrease the glomerular filtration rate and increase serum potassium levels. To monitor the effect of the antihypertensive drugs. Teach the patient and caregiver how to monitor the blood pressure at home and what readings require immediate actions. Interventions for chronic kidney disease mineral bone deterioration include limiting dietary phosphorus, administering phosphate binders, supplementing vitamin D, and controlling hyperparathyroidism. Cinacalcet, a calcium mimetic agent, is used to control secondary hyperparathyroidism. Calcium mimetics mimic calcium and increase the sensitivity of calcium receptors in the parathyroid glands. As a result, the parathyroid glands detect calcium at lower serum levels and PTH secretion. If hyperparathyroid disease becomes severe despite medical management, a subtotal or total parathyroidectomy may be performed to decrease the synthesis and secretion of PTH. In most cases, a total parathyroidectomy is performed and parathyroid tissue is transplanted into the forearm. The transplanted cells produce a some of the cells can be removed from the forearm. Anemia can develop and it's treated with erythropoietin. Darbepoetin alpha is longer acting and can be administered weekly or biweekly. Higher hemoglobin levels and higher doses of EPO, or erythropoietin, are associated with higher rates of thrombolytic events and increased risk for death from doses of EPO, or erythropoietin, are associated with higher rates of thrombolytic events and increased risk for death from serious cardiovascular events such as heart attack, heart failure, and stroke. EPO can increase blood pressure and is contraindicated in uncontrolled hypertension. The underlying mechanism is related to the hemodynamic changes such as increased whole blood viscosity that occur as the anemia is corrected. EPO therapy may lead to the development of iron deficiency from increased demand for iron to support erythropoiesis. Orally administered iron should not be taken at the same time as phosphate binders because calcium binds the iron, preventing its absorption. Most iron sulfate injections or sodium ferric gluconate complex in sucrose injections. Statins, which are HMG-CoA reductase inhibitors, such as atorvastatin, better known as Lipitor, are used to lower LDL cholesterol levels. Statins should be used on patients with chronic kidney disease, especially patients with diabetes that are not yet on dialysis. Fibrates, which are fibrin acid derivatives, such as gemfibrozol or Lopid, are used to lower triglyceride levels and can also increase HDLs. Specific drugs used in these classes depend on the individual patient response. Chronic kidney disease causes decreased elimination that leads to an accumulation of drugs and the potential for drug toxicity. Drug doses and frequency of administration are adjusted based on the severity of the kidney disease. Increased sensitivity may result in drug level increases in the blood and tissues. Drugs of particular concern are digoxin, diabetic agents such as vancomycin, and opioid medications. As previously mentioned, cardiovascular changes can accompany chronic kidney disease. One of the things we want to talk about is blood pressure. It's recommended that the target blood pressure be less than 130/80 millimeters per hemoglobin for patients with chronic kidney disease, and less than 125/75 for patients with significant proteinuria. Orthostatic blood pressure monitoring should be done periodically to evaluate the effects of the antihypertensive medications. Other treatments for hypertension include weight loss if the patient's obese, therapeutic lifestyle changes such as exercise, avoidance of alcohol, therapeutic lifestyle changes such as exercise, avoidance of alcohol, smoking cessation, dietary recommendations like the DASH diet, and administration of antihypertensive drugs. Supplemental folic acid. Up to 1 milligram per day is usually given because it's needed for RBC formation and is removed by dialysis. Blood experiences an acute blood loss or has symptomatic anemia displaying dyspnea, excessive fatigue, tachycardia, palpitations, or chest pain. Transfusions increase the development of antibodies, thus making it more difficult to find a compatible donor for a kidney transplant. Multiple blood transfusions may lead to iron overload because each unit of blood contains about 250 milligrams of iron. Calorie protein malnutrition is a potential and serious problem that results from altered metabolism, anemia, proteinuria, anorexia, and nausea. Additional factors leading to malnutrition include depression and complex. For the patient who is undergoing dialysis, protein is not routinely restricted. For chronic kidney disease stages 1 through 4, many healthcare providers encourage a diet with normal protein intake. Teach patients to avoid high protein diets and supplements because they may overburden the diseased kidneys. Frequent prealbumin, which may be a better indicator of recent or current nutritional status than albumin, and ferritin and anthropometric measurements are necessary to evaluate nutritional status. All patients with chronic kidney disease should be referred to a dietitian for nutritional teaching. For patients with malnutrition or an inadequate caloric or protein intake, commercially prepared products that are high in protein but low in sodium and potassium are available. As an alternative, liquid or powdered breakfast drinks may be purchased at the grocery store. Dietary protein guides for peritoneal dialysis differ than those for hemodialysis. Peritoneal dialysis protein intake must be high enough to compensate for the losses so that nitrogen balance is maintained. Water and any other fluids are not routinely restricted in patients with chronic kidney disease stages 1 to 5 who are not receiving hemodialysis. For those receiving hemodialysis, as their urine output diminishes, fluids are restricted. Recommended fluid intake depends on the daily urine output. Generally, 600 ml from insensible loss plus an amount equal to the previous day's urine output is allowed for patients receiving hemodialysis. Patients with chronic kidney disease are advised to restrict urine output is allowed for patients receiving hemodialysis. Patients with chronic kidney disease are advised to restrict sodium. Sodium-restricted diets may vary from 2 to 4 grams per day. Instruct the patient to avoid high-sodium foods such as cured meats, pickled foods, canned soup and stews, frankfurters. Potassium restriction depends on the kidney's ability to excrete potassium. Dietary restrictions for potassium range from 2 to 3 grams. Teach patients receiving hemodialysis which foods are high in potassium and to avoid them. Patients using peritoneal dialysis do not need potassium restrictions and may even be prescribed oral potassium because of the loss of potassium with dialysis exchanges. Some foods with high potassium content that should be avoided are oranges, bananas, melons, tomatoes, prunes, raisins, deep green and yellow vegetables, beans, and legumes. As kidney function deteriorates, phosphate elimination by the kidneys is diminished and patients begin to develop hyperphosphatemia. By the time a patient reaches end-stage renal disease, phosphate is limited to approximately 1 gram per day. Foods that are high in phosphate include meat, dairy products, and foods containing dairy products. Many foods that are high in phosphate are also high in protein. Since patients on dialysis are encouraged to eat a diet containing protein, phosphate binders are essential to controlling the phosphate level. Because many drugs are potentially nephrotoxic, ask the patient about both current and past use of prescription drugs, over-the-counter drugs, and herbal preparations. Medications of concern are antacids, decongestants, and antihistamines. Non-steroidal anti-inflammatory drugs or NSAIDs like aspirin, ibuprofen, and naproxen can contribute to the development of acute kidney injury and the progression of chronic kidney disease, especially if taken in higher doses than recommended. Assess the patient's dietary habits and discuss any problems regarding any recent weight changes. Assess the patient's support systems. The choice of treatment modality may be related to support system availability. Okay, so what are we as nurses autonomously concerned about? Excess fluid related to impaired kidney function, risk for electrolyte imbalance related to impaired kidney function resulting in hypocalcemia, hyperphosphatemia, and altered vitamin D metabolism, imbalanced nutrition, less than body requirements related to restricted intake of nutrients, especially protein, nausea, vomiting, anorexia, and stomatitis. Most patients who have chronic kidney disease receive their care as Most patients who have chronic kidney disease receive their care as an outpatient. It is not uncommon, however, for patients to need acute care for their comorbidities such as diabetes, and they may need nursing assistance to manage both conditions while in the hospital. Individuals identified at risk need to take measures to prevent or delay kidney disease. Most important are measures to reduce the risk or progression of cardiovascular disease. These include glycemic control for patients with diabetes, blood pressure control, and lifestyle modifications including smoking cessation. Focus of nursing is to reduce complications from conditions that go along with chronic kidney disease such as diabetes and hypertension. As discharge is planned, nurses should be teaching or reinforcing previous teaching. Acceptable management will reflect fluid and electrolyte levels and weight. Also, management of comorbidity conditions. Maintaining acceptable lab values, especially hemoglobin and hematocrit, and no edema, no complications. Acceptance of chronic disease is demonstrated by compliance with medical regimen. All right, so our summary question here is the nurse teaches a patient with chronic kidney disease about the prevention of complications. What should the nurse include in the teaching plan? A. Monitor for proteinuria daily with a urine dipstick. Measure urine. C. Take calcium-based phosphate binders on an empty stomach. D. Check weight daily and report a gain of greater than 4 pounds. And logically looking at these answer choices, we know, first of all, that A is not the correct answer because patients with chronic kidney disease have proteinuria. We know that. Have proteinuria. We know that. It's an expected finding. Calcium-based phosphate binders should be taken with meals. Self-catheterization is not only not recommended, it may actually lead to infections. So the only correct answer is D, and that's what we tell our patients, that they should report any weight, especially a significant weight gain.